All right, guys, we are at the end of this little, I wouldn't say journey, because unfortunately, uh, this will be probably causing you to have headaches for the rest of your life. But as you get more and more EKGs under your belt, the better you are going to be at this. But as you're first starting to learn it, a systematic process is absolutely necessary. Okay, and I'm going to try to teach you my version of it when we start doing some papers in the classroom. But let's talk about how a good approach to handling your reading of an EKG. All right, and so again, we got a little simple algorithm here to kind of determine how it is that you would analyze it. So the very first thing is analyze your rhythm, okay? So remember that when we first started EKGs and EKG practice, one of the biggest things I said is you got to learn the base rhythms, okay? Absolutely have to learn the base rhythms, okay? You got to be able to tell what exactly you have, all right? You want to determine your axis and if you've got any type of hemi block that might be going on. Determine if you've got a bundle branch block, all right? And I will tell you right now, not so much the hemi blocks. I think that it's important to learn as you get better, but the determining the axis, I believe, is a key step. Okay, just absolute key step, because again, it's going to tell us whether or not, especially the axis. Axis is going to tell us whether or not this patient's in VTAC or not. All right, it's a quick, easy method in order to tell that. All right. So determine if you've got any type of bundle branch blocks, and then you're going to do the ISAL, okay? Right? I see all leads, or inferior septal anterior lateral, all right? And we're going to be looking for ST elevation, all right? So get your 15 lead, get your V4, V4R, V8, V9, okay? And then again, do I have a left bundle branch block or some sort of an AMI going on with this patient? Do I have a subendocardial injury, meaning do I have ST depressions where it's not yet progressed to where we can actually see it, all right? Do I have any type of chamber enlargements that might be going on, okay? And again, I would say probably as you're beginning to do it, I wouldn't worry about that one too much, okay? The QTC interval, if you're going to give an antidiuretic or if you're going to give diuretics, this one right here, I would definitely 1000% want to make sure that I don't have an elongated one. Because if I have an elongated one, I don't want to give antidysrhythmic medication. All right. And then again, do you have any type of special things? Early repolarizations, pericarditis. Okay. So when you're doing your assessment of them, all right. But this is kind of the key part of the steps here that I want to make sure that you guys get right. Okay. Make sure that you do this on every EKG. So it's a beautiful little thing here. Analyze your rhythm. Do I have a wide complex tachycardia? Okay. Again, use VTAC, and if you don't have it, that's good. Identify the rhythm. Figure out whether or not it's going to be VTAC or not. All right. You got an axis or hemi block. The QRS is greater than 120 seconds. Again, I got to determine whether or not I do have a bundle branch block. If I got a left bundle branch block, it's got special criteria in order for us to actually call it a STEMI. Here's my criteria. This is where you hand off your bag of crap to somebody. You need to let the doc know that you've got this particular thing. But if I've got a right bundle branch block, then I want to just assess whether or not I've got all my leads here. Okay? So, again, do your 15 lead and then figure out what it is that you have. Okay? What type of injury that you might have. Can I give antiarrhythmics with this? Okay? So when you're doing your analysis, this is the pattern I want you to follow. Okay? First question you need to ask, is it VTAC? All right? If that's the thing I really want to know. Is it VTAC? All right? If I can't figure out whether it's VTAC or not, again, we need to figure that out. We need to figure out because we change it. We treat the patient differently. All right? If I've got, again, axis or hemi blocks, if I got a QRS that's greater than 120 milliseconds, I got to figure out what kind of a bundle branch block it is. If it's not a bundle branch block, and then I'm going to go down here, then I'm going to decide if it's going to be a myocardial injury. If I got a left bundle branch block, again, hand the doctor the bag of feces, okay? Hand him that one, all right? Again, are there criteria for this? Yes, it's the Scarbosa criteria, the checklist. Me personally, I think that it requires an over-analysis that a lot of times paramedics get wrong. But it's not that you can't learn that material. It's just that I wanted you guys to get a little bit more experienced before I get you into that particular criteria. Now, again, do I have any type of injury going on, and then get a comprehensive assessment? And again, how do I treat the patients as needed? All right. If you follow this pattern, guys, I assure you that you're going to have a lot better success at doing your 12 leads. Okay. The biggest thing is, again, circle these 12 leads. And you guys have seen the way that I have analyzed these 12 leads as we've gone through some of the lessons here. So again, I'm going to look at my strip, okay? Guys, I've seen these strips before, obviously, but again, I don't actually have the true, honest answers. I've got the book here, but again, I haven't looked at it. So again, I'm going to look at this one, all right? Do I have VTAC? Well, number one, I got a bunch of irregularity there, so I would say probably not going to be VTAC. Okay, my QRS, it is wider than 120 milliseconds, so I know that so at this point, but I'm pretty sure that it's a supraventricular rhythm. Okay, so with that being said, I know that it's not VTAC. Again, irregularity here. I do not have VTAC. All right. Let's erase this here. Erase all link. There we go. But I definitely think I got a bundle branch block, and because I've got a bundle branch block, it's going to be a right bundle branch block because of what I did here. So again, this one's pointing up. I would look at V1 in order to figure that out. So I've got an atrial fib with a right bundle branch block. Why do I think it's AFib? Because I got the irregularity here, which I'm not seeing any really defined P waves on any of these leads. Okay. My axis, by the way, my R axis is 91. So again, if I draw my axis, 91 is kind of like this. So I've got some right axis deviation. All right. And by the way, if I've got AFib, that's probably a normal finding to have that. Okay. But left or right, more than likely right is what we're going to have here. All right. So do I have any ST elevations or depressions? Nothing of blowing my kilt up here. But I do have a lot of T-wave inversions. Again, that could be a normal variant for this patient. All right. So long and the short, do I have anything that's going to acutely cause him to have a problem in the next few minutes? No. Do I have it to where, let's see here, 5, 10, 15, let's say 20, 30, 35. Okay, so he's got some right axis deviation. He's got some atrial enlargement here. Okay, so he's definitely got some issues going on. But as far as him needing does he need to go to the cath lab right now? I guess that's the things that we're trying to figure out. Is he in VTAC? Does he need to go to the cath lab yesterday? Okay, and at this point, I would say no. This guy does not need to go to the cath lab. I don't think that he's having an MI at this point. And again, the only thing that might be just a smidge bit of suspect is right there. I'm not seeing anything as far as any other lead. I'm okay with that. Let's keep going. So I'd say he's pretty good. Let's look at this guy. Ooh, nice bradycardia, that's for sure. Heart rate 41 beats a minute. Let's see here. My axis, let's see here, 59. So we're looking pretty good there. So my axis is, there we go, 59. Hey, 59 is normal, physiological, right? All right, so I got a P wave, I got a QRS, I got a T, we got some rabbit ears there. Okay, the QRS is wider than 120 milliseconds. Oops. So do I have VTAC? Well, definitely at a rate of 41 a minute. I'd say probably not. He's got a P wave anyway, so this is supraventricular. And looking at the end of it, he's got a right bundle branch block. Now I need to start seeing if I'd see any ST elevations or depressions. See, I'm depressed there. I got a flip T wave there. See here. don't see any elevations per se. All right, so far I'm actually okay with this one. All right, no real elevations, but I do have a sinus bradycardia of this patient. All right. And I probably would want to speed that heart rate up if I had to make a treatment plan based upon that EKG. Definitely want to speed that one up. Let's see here. Got some right axis deviation going on. QR restoration's nice and thin. Got some PVCs going on. It's got some funny little beats. That makes the fun of interpreting all these things. So, by the way, guys, when we're talking about ST elevations, if they've got PVCs, throw those out because those don't really count, okay? You want to look at the regular underlying rhythm here. If I'm looking at lead 2, it's kind of all over the place. I have P waves here. I got a P wave there, PQRST, PQRST, additional PV. Boy, the first thing I'd say is I want another EKG tracing. Because, again, do I have any really clear signs? I got some major issues as far as clear signage here. QRS is 112. That's good news. No bundle branch block. Is this VTAC? Down. No, it doesn't meet any of the criteria for VTAC. V6 is primarily up, so we're good. All right. So I don't have VTAC. That's the good news. Don't have a bundle branch block. All right, no bundle branch blocks at all. So again, this is a sinus with and I would say unifocal PVCs because they appear to be the same shape as far as, and when you're talking about shape in this one, you're talking about a shape in the same lead, okay? Well, that one looks different from that one, Scott. Well, no kidding, because it's a different camera angle. Look at the same camera angle, all right? And again, if you're going to diagnose that, then you'd say they really need a longer strip. As far as ST elevations or depressions, I'm not seeing anything that's really catching my eye. So, although we do have the PVCs, I think we're okay with that one. As you guys see here, whoa, hello, nurse. Good luck on this one. Let's see here. That one's pointing up, a steeple sign. Do I have P waves? And that's a really good question on this one. And I'm not seeing P waves on this one. V6 is primarily down. Actually, let's see here. What is my R axis? 160. So it's kind of like this direction. Ooh, yeah, this is a nightmare. I'm going to tell you why I think this one got the steeple. That's where I'm kind of having the hang up here, gang. I've got a steeple sign right there, and V6 is really down, okay? That, even though this is down, up, but that one's up. But the things that I'm seeing here is the steeple sign and the V6 is down. Yeah, I'm thinking VTAC here, gang. You might not think that. I'm thinking it's definitely VTAC. Well, that looks normal, Scott. That looks normal. Yeah, it's VTAC. Okay, so again, I'm thinking at this point it's probably going to be time to have the lightning ride here, unfortunately. Next. And one more that we're going to do here, and then we'll call it a day. Ooh, look at that elevation. Oh, holy macrimony. Nice elevation there. It's a junctional rhythm, by the way. I'm not seeing P waves. Ooh, look at that ST elevation. Let's see here. That's not exactly great. Is this VTAC? No, I don't see. It's a way narrow QRS complex, so VTAC's not in play here. Let's see here. The axis is minus 22. Yeah, we're good with that. Got the depressions in this one. 4 is okay. 5. Actually, I'd say that's a little bit elevated on both of these guys. So an interior lateral. So my diagnosis of this one would be a junctional. This would be a junctional. We got ST cell in the inferior leads. All right. Guys, we are going to practice these a ton more once we get into class. And I can't stress that enough. We're going to practice this a whole lot more. We're going to be circling. We're going to be throwing the pen up there. We're going to say, hey, you tell me where you're seeing stuff, okay? And we're going to go through it together. And again, as you're practicing these, do what I just did, okay? Is it VTAC? Is it a bundle branch block? Do I have ST changes? All right. If I can do those three things, I've just solved a lot of my problems. So again, you got to learn the different parts of that. You got to know your ISAL. You got to know what part is affected. Okay. That's going to do it for 12 leads. Hey, 12 guys. This is not even close to everything that there is to know about 12 leads. Not even remotely close. It is a starting point for you guys, okay? And as you go through your career, you're going to get better at it. You're going to learn more things. There's all kinds of different criteria that you can see different subtle things. What I'm trying to teach you here now is how to pick up a STEMI, how to make sure that it's not VTAC. That's what I'm truly after. All right? Good luck, and we'll deep dive into this a lot more when we get to the classroom. So I will see you guys on the next one.